are going to talk on the screening and diagnostic test. Because I think currently we are with the current COVID situation. Also, lots of things are discussed on screening and diagnosis, and so you would quite common that you hear about the sensitivity, specificity. So we will learn all this. Okay. But I hope that you have gone through because there are the calculation part in kappa equation where you need to understand that because the session is only 1 hour, so I don't think we can. If it is long, we can go deep into the discussion. But I'm not very sure whether we can finish in 1 hour. Anyway. So when we talk about screening, the other one is diagnosis. The screening here, this definition of screening is a process of identifying healthy people who may be at increased risk of disease or condition. So screening is what we have at the shopping malls. Students do screening for the public. You have some expo or whatever, there is a booth where there is a screening. So normally the screening that is very common is blood pressure, blood pressure and also sugar. That is very common. That is been done quite because it's BP is always quite free, whereas blood sugar is issue of reagent only lah. The test the stick, the stick for the test. So the idea of screening is we want to identify healthy people. So if you have got the chance, you are in the vicinity of this screening area, please go. Please go because you will learn that whether your blood sugar is okay or your BP is okay. Because this is the thing that some people only discover that they have got some condition through screening. Yeah. So the screening provider then offers information for the test and treatment. So normally when we have gone to this screening center, if negative, it's okay. You can go. But if positive, normally the person will advise you for what next to do. So that is the beauty of screening. Screening is just a random, very random to all the population. And then if you have got a positive, for example, for blood pressure, then there is a need to go to see a doctor to verify whether this screening, because the screening done for your BP is actually done by the electronic gadget, the BP set, which is battery powered. So it can be a mistake there. So that's where that is the issue. Yeah, the issue of screening. Why some people do not do screening. Normally we will do the further test at the clinic to verify that the screening that we have done is right or wrong. Yeah. So we'll see the implication. What if it is right, false negative, false positive. This is to reduce associated risks or complication. Yes. So if you discover things through this manner, through screening, you can actually remedy it easily. You discover that your BP is high, is easily. You can actually, through exercise alone, you can actually reduce your situation or reduce your salt and so on. If it is diabetes, sugar, increase in sugar. So you once you know it, of course you will be alerted yourself to take care of your diet and so on. So I've got these two sites here you can go through, and also there is a YouTube, quite very simplified version of what we are discussing here. This is under definition of National Screening Committee, and we have another by WHO saying that the screening refers to use of simple tests across an apparently healthy population in order to identify individuals who have risk factors or early stages of the disease but do not yet have symptoms. Yes, so that is the whole idea of screening. Screening is actually to identify normal people, to check the normal people whether they have got any early stage of disease, because they have no symptom. They are asymptomatic. Just as our challenge now, the COVID, the positive cases, the majority are actually asymptomatic. They are asymptomatic, not no sign, no symptom, and yet they are positive, and they can transmit to others. That is the our concern with the COVID situation. Yeah. Okay. This is what the current DG. Yeah. He is already Tan Sri. Yeah, Tan Sri Datuk Dr. Noor Hisham. This is in 2015 when he says this. The decision to screen for a disease must be made on a sound basis and take into consideration elements of treatability and progression. That the pillar of health service in the country, primary care, plays a very important role in identifying disease early, focusing on screening and early intervention for selected medical condition has much lower cost than treating after late detection. The saying prevention is better than cure is very true. Therefore, a good screening tool based on sound evidence is very essential. So all this, the one that from UK, from WHO, and this one, these are quotation of people to emphasize on the importance of screening. Because screening, if you identify early, you manage it is actually at a lower cost. So you can save cost to the government, save cost to the family also, if it is there is no insurance system and so on. So the early stage is always things that we want everybody to apa to go through, to go through in order to prevent the worst that could happen in our body. Yeah. So this is in one document, consensus guide for adult health screening in general population attending primary healthcare. Okay, so as I said earlier, screening is to detect a disease in individual without sign or symptom, asymptomatic at all. If he got a high BP, he or she didn't have even a headache, nothing, no headache. There are people like that. They are out of any. They have no vertigo. They have no headache, and yet they have got a high BP. Case finding. So another way of screening is case finding. Is testing a person for diseases not related to his or her complaint. So by screening, we can actually test somebody. They don't have any complaint, but we found somebody. Usually an investigation of exposed people to sort the exposed and ill from the exposed and well. Example, in the current COVID-19 situation now, we have the person under investigation or person under surveillance. Investigation is those close contact, and surveillance is second level, second tier and so on. The diagnostic. So besides screening, we have the diagnosis. So this is looking for suspected condition which is tested. So those we screen before positive. So now we have to confirm it, to confirm or to exclude any false diagnosis in the screening, because the diagnosis, the screening, when the person who make the screening, it is actually like a diagnosis, like a preliminary diagnosis. So that this is the thing that we have to be very sure when we tell the client, when we tell the person, the audience, the person who came to our screening, that is this is a preliminary finding. Preliminary finding is not yet confirmed. So so it will be done by proper diagnosis. So so diagnosis normally, when people got symptom lah, when you go to the hospital, they will do the proper laboratory diagnosis that will confirm the condition. It's a matter of finding the level of the uh, whatever level lah, blood level, some level. So screening does not diagnose. So you, as I mentioned earlier, screening is preliminary diagnosis, but it is not a real diagnosis. So those with positive result, we undergo further test or investigation. Quality of screening. This is where the issue of screening tools. The quality of screening is very, very important. We will discuss about that later. Early detection, better prognosis, treatment, and so on. Screening test useful because for serious disease and high prevalence. So in our situation, like diabetes, 20% in the population, hypertension, very high, about 30 to 40% in some communities. So it is good to have this screening because we can detect the way that is what is being done in Selangor now, FTTIS, find, test, forgot what is FTTIS. It's actually screening, screening. What the Selangor state government is doing in the Selangor districts, they are going around and have the halls, community hall, where they screen the population. Even though by doing that is they are actually detecting more cases positive of COVID-19. But to me, this is the best way. It's the best way because COVID-19, the range of symptom is very wide. It is from asymptomatic at all, which is the majority, that going around, walking around, going to the malls, going to a restaurant, and so on, to the extreme of having ICU, cannot breathe, have to be treated in ICU with a ventilator and so on. So that is the extreme. So what the Selangor government did, to me, I really appreciate what they did, because this is actually to make the people aware of themselves. If they are positive, yes, you have to go for the investigation. But if you know that you are negative, then make sure that you take care of yourself with the SOP and so on, so you are not the risk to other people. Okay, so screening is at the level of subclinical disease before the onset of symptom. So we have a risk of disease. So any people, they have risk of disease. So we are all healthy, inshallah. We are all healthy people. So but we have the risk of a disease. So when we do the screening, we can either have a false negative test. False negative means you are positive, but you are false the test shows that you are negative. So this is the this is the disadvantage of screening, yeah, in terms of its sensitivity and specificity. Yeah. So adverse effect of procedure. So sometimes to do the screening, you have to jab to take blood, for example. So that's why now for blood for glucose, for example, it just a prick at your fingertip. So it is not drawing much blood. Okay, and so if it is a false positive, the effect is actually not good. So you found that these people is actually have some problem, but you diagnose as negative of a certain condition, then it has got a implication on his health in the long run. Referral. So if it is positive, we refer for diagnosis. So non-adherence to follow-up tests, psychosocial impact of false positive tests, adverse effect of procedure. Okay. So when it is referred by the screening, it is positive. So the issue is sometimes it is actually false positive. Uh, false negative also you have problem. If false positive is also a problem, especially things like test for HIV, syphilis, for example. If you are diagnosed as positive, that is already a taboo to yourself and to the families and so on. But it's actually negative, false, false positive. So it means you are negative. Then it will cause a psychosocial issue, impact on that false positive test. So if it is confirmed with the diagnosis, we will refer for treatment, and then this is where you get all the benefit of the treatment as well. Okay. So to us, what is the criteria of good screening tools? So because those medical related companies, they innovate and they are very innovative. They come up with various instrument. There are so many instruments out there. You can buy in the Shopee or Lazada screening tools. Now they are promoting oximeter to measure your oxygen level in your blood, because that is indicate whether your lung is functioning well or not. Because this is the COVID situation if it affect the lung, it actually will make a hypoxia. And types of screening test in Ministry of Health. So we discussed a little bit of the KKMs or Ministry of Health Malaysia's screenings, what they have got. Yeah. So okay, this is the characteristic of good screening. Characteristic of good screening. One, it must be valid. What is meant by valid is it must be sensitive and specific. So it means that it must have a high sensitivity rate and specificity rating of this particular screening test tool. So it must be valid. So if it is not valid, then there's no point of using that test. It must be reliable, give consistent result, no random errors. So like our BP set that we use, the digital one, use battery. I'm very confident that if I put on myself, I'm very confident of the result. There might be a slight error only, maybe 5 mm more or less. It cannot be such a big drastic difference. Yeah, so it's reliable. Yield number of cases identified per thousand screen. So yield, whenever we use this throughout, it is good. There is no complaint. It is quite consistent in numbers with numbers. Cost benefit. So cost benefit, we talk about the if we detect early, you can actually save the person in terms of cost in the medical treatment and so on. And then it should be acceptable. Acceptable mean uh, uh, it doesn't cause discomfort, discomfort, hassle, cost obtaining the test, and so on. So it must be acceptable. It's cheap. It's cheap. It doesn't take a lot of blood. Hassle free. You just go in, just like you vaccine session now. Go in, sit down just for to check up to ensure that you are okay. Go for the jab and wait for 15 minutes and can go back. So such a hassle-free situation. And then follow-up service. A plan needed to deal with positive results. So there must be the next. What next? If it is positive, what next? If it is negative, what next? So this is the characteristic of good screening test. And so this is the situation when you do the screening. Negative. So negative can be a real, can be no disease, that is true negative, true negative, and also it can be actually false negative. That person actually has got a disease. The same thing with the positive result. If it is positive, it can be real, true positive, but also there may be a false positive. Actually, even though that person is positive, but actually he is actually no disease. So this is the issue of screening. Yeah? So we have also an ethic of screening. Ethic of screening is first, any screening, any test with a human, you must get a consent, informed consent. So if it is at the shopping mall, when you go, they will ask you to sign first that you agree to this, because that information is actually can be done as a cross-sectional study. They can use that information. So normally what they did at the shopping malls, all these things, is actually they gather the data for some studies and so on. If not studies, they can actually assess the community situation, the community health status. Yeah. Uh, Second is the implication if positive result. So positive because when you do screening, positive can be two. It can be false positive, it can be true positive. So you have to be careful. You have to make sure that you are ready for this. What you shall do. Number of implication of false positive. If it is lot of false positive, what you should do and your explanation. If it is false negative, maybe false negative, also a problem because you test negative, but actually that person has got some problem. So these are the thing that you have to be concerned to make sure that when you tell them, you must tell the truth of this. What you do is actually just what call a screening, just a screening. It's not diagnosis. It is not a diagnosis. It's just a preliminary diagnosis that it may be wrong. Yeah. Labeling and stigmatization. Stigmatization, as I mentioned earlier about the HIV and so on. So that might be this. labeling and stigmatization in the community, especially in our community who always talk bad about people. Uses of screening, case detection, prescriptive screening, presumptive identification of unrecognized disease does not arise from patient's request. So screening is not based on patient request. Sometimes you do it when patient is admitted for other condition, but you do this test in order to check whether this person has got a problem or not. People screen for their own benefit. Yeah, so their own benefit. Example, neonatal screening, bacteriuria urea in pregnancy, breast cancer, diabetes mellitus, iron deficiency disease, control of disease. So what we are doing COVID screening is actually control of disease. We want to identify who are positive, so they can be isolated, quarantined, so that they will be able to control the government will be able to use this information to control the disease. People examine for benefit of others. So those positive, for example, COVID positive. So once we know, the person also know that he won't be able to go to, because with the glove, with the wristband, colored wristband, he cannot go. He cannot cut also, because if he cut, it means that he had already breached the order of keeping it until he is cleared. Secondly, we know that these people are with the ban. They should not be around with us in the shopping mall. They should be at home, quarantine. Of course, there are few caught in the in the shopping mall, restaurant, and so on, as in the news. People example, screening of immigrants for syphilis. So when immigrants coming to our country, we gather them, so we check for this. So if it is positive, then we know that we can treat them, and also we can actually control the spread. So the other purpose of screening is for research purpose. So this is quite common. In year 3, we have got this HIP, Health Intervention Program in Sepang for during the public health posting. So normally the student will do what we call the survey of the community that are allocated to them, and they will interview the households over there based on how many they should screen, and and the data are generated and can be published to describe on the status of the community health. Yeah, so this is what we are ongoing in Sepang district, where our student during the normal time, not now, the normal time, they will be able to go and interview the community with the approval of the community leaders, and after that they will churn the data into some information for the community. So we will present them during the 1 day session, when they like expo, 1 day expo with the community, where we will display all the posters about what is the health status of the population of that community. Yeah, and then at the same time we will have talks, we will have advice what are the things that they should do in order to prevent spreading of certain condition in the community. Normally we have the same issue of obesity, issue of hypertension, diabetes, inactivity, no obesity. So we will teach them, teach the community, and we hope that by our advice, the people in the community will be able to adopt our advice and try to change their lifestyle into taking food that is suitable and has got some values for their health. Educational opportunities. So we can some educational opportunities when do the test. We tell like a session, what we call educational session. We'll inform the community, and teach them what they should do. So in Malaysia we have this COSPEN program. COSPEN is under the Ministry of Health. COSPEN is pembina negara. What is it? But this is to taking care of your health for the national benefit, something like that. So this is in my place where we have the training, the health people, Ministry of Health people um, do the training for us. So make use of the BP sets and blood sample. So we do it on 1%. So we have mass screening, high risk or selective screening, multiphasic screening. So multiphasic like application of 2 or more screening in combination to a large number of people at one time. So this is quite expensive lah. Mass screening that we always quite familiar with. And high risk is to a certain high risk group. Maybe the elderly do some certain test for prostate screening and so on. So targeted to a certain group. Okay, so the difference between screening test and diagnostic test. So diagnostic test is something that is almost like 100% correct. So if the issue of our screening is always the issue of there might be a issue of false positive or false negative, but for diagnostic test is actually to confirm all those false positive or false negative to ensure that the diagnosis will be right. Yeah. So diagnostic is always considered as a gold standard. Yeah? It is called gold standard. So in our situation currently, we have the PCR. It's a gold standard. It's a gold standard. We have the RTK, RTK for COVID-19, rapid test kit, use of rapid test kit using agglutination method, and normally this rapid test is as you saw the characteristic just now is simple, no discomfort and so on. It is actually done very fast. 1 hour you can get the result. Within 1 hour, you can get the result from the same swab and from the same nasal and also throat swab. You do the throat swab. For diagnostic for PCR is actually at least 1 day. Previously it was 2 days plus, can be 2 or 3 days, but now it is only can get it within 1 day. Yeah. So so screening is to detect potential disease, whereas diagnostic is established disease. Target population is those out there with no symptom at all, whereas diagnostic test is on those already with symptom or asymptomatic but positive with screening. So 2 situations. Those who are admitted to hospital, for example, tests are done on them and just to verify whether they have got this particular condition or not. And the other one is asymptomatic. Those we screen and positive, so we have to make sure that they have got it is the right diagnosis. So the test method, so like screening is very simple and quite easy to be done by the staff. It can be easily done by medical staff or maybe student also can do. Whereas diagnostic is maybe invasive, it is maybe expensive. You do some MRI, CAT scan, CT scan, and so on. Yeah? But justifiable as necessary to establish the diagnosis. So MRI, for example, is costly, but you have to do it to justify. It is justified to do it because you actually get the real diagnosis. What is wrong with this person? Positive result threshold generally chosen towards high sensitivity, not to miss potential disease. So we talk about this one later. Chosen towards high specificity. What is sensitivity and specificity and sensitivity? Specificity. Positive result essentially indicates suspicion of disease. So if it is positive for screening, is suspicion of disease, not yet the disease. So that's why we have to put a disclaimer here. Whereas for diagnostic, result is actually definite diagnosis. Cost, as I mentioned earlier, this can be cheap and high cost in diagnostic. So because of this issue of reliability, validity, and so on, so the WHO come out with this guideline on screening in a long time ago, 1968. This is what they want. If any company want to come up with the screening tools, they must comply to this condition. Should be important health problem. Yes, diabetes, hypertension is a big problem. There should be a treatment. Yes, there should be a treatment. So what about COVID? There's no treatment. Yeah, no treatment yet. Even though there are people who claim ivermectin, chloroquine is also can cure. But so in a way, the screening that is being done now, it doesn't comply to this. But it is important because we know that the situation is very grave that we don't check, we don't identify, it will be spreading like wildfire. So even though there's no treatment, we have to continue still doing the tests. Facilities for diagnosis and treatment should be available. So once you get the positive case, positive for hypertension or diabetes, next is there is a diagnosis and there is going for treatment. There should be latent stage of the disease. Latent stage of the disease is like incubation period. There should be tests or examination for the condition. There should be acceptable to the population, acceptable, no discomfort and so on. Yeah? Natural history of the disease should be adequately understood. This is also another area where the current one, it is still not yet really understood. So by right, screening tools should know the natural history of the disease and should be understood. Should be understood. Natural history of the disease should be understood. But now we are still uh, compiling all the evidence, all the what we call the characteristic of the disease. Always updating it. So, but of course, it is something of the global issue now. We should accept it. There should be an agreed policy on whom to treat. So recently you hear what happened in other country, where the doctor decide who will live, who will not. Uh, very very grave situation, where there are so many patients looking for oxygen, and finally because it's not enough, so the doctor have to decide who who to treat, who can live, who cannot. Oh my God. So we hope that it doesn't happen in your career to do this. The total cost of finding a case should be economically balanced in relation to medical expenditure as whole. So it should be cheap. It should be cheap. The cost of doing screening should not be uh, so expensive. Case finding should be continuous process, not just once and for all projects. So this is the what we call the tools. These tools of screening should be used continuously, not just once and after that you abandon it. Okay, so these are the common screening that has been done. Cardiovascular risk factor screening, thoracic dysfunction, osteoporosis, chronic obstructive pulmonary disease, cervical cancers, breast cancer, colorectal, prostate, for tobacco, for tobacco, alcohol, um, used by police also, alcohol screening to test your breath analyzer, illicit drugs, all the drugs that are tested to identify HIV, depression, scoliosis, hearing loss of in elderly, visual impairment, risk of fall in older people, dementia, urinary incontinence, and so on. Yeah, so many common screening. So I will not go into this. You can read on your own some of the requirement, age, and so on. Okay, males and female. First one is males and for females because they are different. So these are the common screening. Blood glucose, very common for diabetes type 1 and 2. Blood profile. So this is if you normally you take the blood, normally there is cholesterol also, LFT. Alpha fetoprotein, newborn blood for thyroid disease, cystic cystic fibrosis and blood level test, hearing test in children, blood pressure measurement, hypertension, bone densitometry, personal ECG monitor. Cancer screening is quite common, pap smear or liquid-based cytology, mammography, colonoscopy, hematological, and so on. Yeah. Okay, so just to show you some of the screening that is being done in Malaysia, for example, because of the you see the prevalence, about 1 in 19 women in this country have got this condition, as compared to 1 in 8 in Europe and US. So the prevalence is higher in Malaysia. So having this screening is actually good. So we have and as a nation teach how to do the self-breast examination, and at the same time further we can do BSE is not a screening, but however women are encouraged to do BSE monthly to detect any abnormalities in their breast, assessment of breast lump. We have this if lump is suspected through BSE, so they have to do triple assessment, clinical examination, can go to a hospital, or radiological assessment. We have a mammogram, we have ultrasound, and also fine needle aspiration. So if it is all negative of benign, so it's probably benign. Yeah? So it just so because the issue in our country is that people tend to not to uh, not to accept that if there is a nodule, for example, in the breast, so if it is in other places, they would go immediately to make sure that it is biopsy is done, check, for example, to ensure that it is not malignant. But in our country, it's quite common that people just leave it until it's already stage 3 or 4, where only then they go to the hospital. Yeah. Cervical cancer screening. There is a guideline. You can access this book. It looks like coronavirus also, the picture. MOH has introduced HPV in 2013, vaccination in 2013 to prevent cervical cancer. So this vaccination to prevent cervical cancer helps. HPV vaccine helps to protect against at least HPV types 16 and 18 that cause a great risk of cervical cancer. According to Malaysian data, despite availability of screening program for cervic uteri cancer, the percentage of cases who presented at late stage was 38.5%. Okay, you can read further, but this is one of the tests. So we have national screening services in Malaysia. We have the premarital. Premarital, we have rubella, HIV, thalassemia, and hepatitis B. During pregnancy for anti for pregnant ladies, HIV, STI, and rhesus. And for the child, the newborn, neonatal period, congenital hypothyroidism, and G6PD. Yeah. We have a syphilis screening starting in 1983. So all pregnant mothers until now is still tested for VDRL and TPH level, and treatment for those who are positive. We have a screening nationwide for colorectal cancer, initiated in 2014. It is done at the health clinic using opportunistic approach. Colorectal cancer screening offered to every male and female age. So this is focused, quite focused on the 50 to 70, asymptomatic, attended the selected health clinic, and they are willing to be screened. So that's what they will do. They will take the immunological fecal occult blood test. The quality is used as a tool to detect the presence of blood in stool. So they take the stool sample. Yeah. Okay. Rubella screening started in 85, but become a immunization program in 1987. Yeah. Immunization for all start with the female student in 96, and I think by 99 started with screening 85, screening 85, but immunization started in 1996. Yeah. Thalassemia belt, so we are in that region also. So we have also screening for thalassemia, starting 2008. Okay. HIV antenatal screening also done. So we have taken a lot of samples. All pregnant mothers are screened for HIV. So number of mothers, pregnant mothers, almost like 100%. The study in 2004, 123 new HIV cases were detected. It's only less than 1% actually. From 74,000 respondents, in 2004, 24 cases advanced to marriage, 37. So even though they have got HIV, but they still want to get married. So 37 of them, very small number. No, 24. 24 cases out of 37. They still but they will be underwent a counseling, and 6 of them married among themselves. So 6 of them out of these 24 cases, 6 of them still they want to marry to the same people lah, same group lah. It's okay lah, kalau same. So our concept, if it is positive, one partner, the other is negative, it's a more big one. But if it is both, then it's slightly different, yeah. Premarital screening, okay. So this is especially the Muslim couple in Malaysia. It is a requirement. If you want to have your marriage to be solemnized, you have to get this done, and there is a validity for the certificate. So the numbers actually a lot have been done. In 2009, for example, 179,000, and the prevalence of HIV is only 0.04. It's very, very minimal, but at least we got it, and a few, at least it is safe to the general population. Cases of HIV in Malaysia getting lower now, yeah. Okay. So we go to the tools, the tools that we are going to use. So this is how they assess the tools or the screening tools. So using this particular, using the tool, the equipment, the tools that you want to use for the screening. In the population, there will be those with the disease and those without the disease. So on the left hand side is here is our test result of using our tools. So we have the positive and negative. Below is negative. So positive, and then in the population, those with the disease, So when I said those with the disease, it means that they are truly positive. If we send for the confirmatory using the gold standard, it is positive. So on the this column with the disease is people with the real disease. Okay. So using our screening tool, it is positive. So when it is positive and that person is actually truly positive, it is become true positive, TP. They have a disease and have positive test. And then we go and negative, but the person is actually positive. Under our confirmatory, they are positive, but our tool says it is negative. So it is called false negative. They have a disease, but our test shows negative. So this is called type 2 error. The other column, without the disease, these are free of the disease, but our test results show positive. So this is called false positive. Actually no disease, but our test is very unreliable. It is shows positive. So this is type 1 error. And then below is also without disease, and our test also shows it is also negative. So it is true negative, no disease, and our test is also negative. Okay, so sensitivity. So this is the term that you have been hearing about, sensitivity of test, specificity of the test. So what does it mean? So this is what it means. Sensitivity means the true positive under the disease in the population. The true positive divided by true positive and false negative. Yeah. So under this column, the number of those true positive plus the true positive plus false negative, Fn. Yeah? That is sensitivity. So it is a measure of true positive. true positive. True for the specificity is it actually a measure of true negative that the people doesn't have the disease. So it is under this column that we have the true negative divided by true negative plus false positive. Um, using our tools, positive, we have got this. You can measure also what is called predictive positive value, PPV and NPV, positive predictive value and negative predictive value. So it is a true positive divided by true positive plus false positive. So you get of that of your instrument what is called positive predictive value. Yeah, and for negative predictive value of your instrument is the number of true negative divided by the true negative plus false negative. So this is what is meant by the sensitivity and specificity. Yeah? So sensitivity is proportion of true positive correctly identified, 1 minus false negative rate. Specificity is proportion of true negative correctly identified as such, 1 minus false positive rate. Okay. Screening test can be harmful, yes. So I think I will leave this to your reading, yeah, because some of the instrument that are being used. So we go to this calculation. Yeah? So just to show, in terms of that 2 by 2 table just now. So we put here example. We put example of 1,000 population. 1,000 population, 100 with the disease, and 900 without the disease. Without the disease. Actual, the true picture of the real diagnostic. Huh? Whereas for our tools, screening tools, we found out of that 100, we found 80 positive and negative 20. That negative is actually uh, false negative, false negative because it is actually true. So sensitivity is the measure of the positive, true positive divided by total of the disease. So it is 80%. And specificity, in this case, we put without the disease, 100. Our tools detected positive 100 and 800 negative, 800 negative. But actually it's 900 without the disease. So the specificity here is actually we take the true negative divided by the total, so it becomes 89%. 89%. So this is the what I call the calculation for the sensitivity and specificity. Yeah. So you can play with these numbers to see that what is it means that if it is higher sensitivity, 95%, for example, what does it mean? It means that the number here, the positive is higher. It's higher as compared to closer to 100. So maybe 90. If it is 90, it will be 90%. If it's 90 here, it will be 90%. Yeah. If it is 90 positive and left with 10 negative. Yeah. Okay. That's the explanation that I've given. So we measure with the gold standard. These are the explanation. If you can read on your own. Go now to the predictive value of tests. How good is a test in identifying people with disease and without disease? If we screen population, what proportion of people who have disease will correctly be identified? This is important in public health and clinical setting. If test is positive, what is probability that patient has disease? It's called positive predictive value of a test. Positive predictive value is proportion of tests that are truly positive, and negative predictive value is truly negative. So in our case just now, using the same table, same number of patient of 1000, here the positive predictive value of our test kit is actually 44%, and a negative predictive value of our kit is we take 800 over total 820, so it is 98%. So negative predictive value is high, it's good, but not so good for the positive predictive value. Okay, that is the explanation. And then we just see here if it is prevalence. We look at prevalence of 1% and prevalence of 5%. The predictive value, positive predictive value is 17% if it is a prevalence of 1%. This is using the same number, but we put prevalence of 1% is 99 over 1. If it is 5%, 500 cases, so we put 495 and 5. So the predictive value, positive predictive value for 5% is actually higher. From 17, it moves to 51%. So this is how to show that in screening is actually good in the high prevalence situation. People with high blood pressure, for example. So you use the screening tool is good. It's good too because the prevalence of the population with 30% prevalence, for example, in the community, diabetes, for example, to use the tool is very good. So you get a higher reading actually. Okay. Therefore, screening program is only efficient if directed to high risk target population. So screening is good in that situation, right? So you can read the explanation. This is actually just the explanation. We give another example of predictive value of neural tube defect for alpha fetoprotein test in high and low risk women. So we have high risk women and low risk women. So low risk, high risk women abnormal is quite high as compared to the normal. And so we have predictive value here is about 82.9%. For low risk women, there is normal women who have got a normal child and so on. So actually the normal, the abnormal becoming less, and the normal will maintain at a very high level. So it means that all this, if it is targeted test in those with high condition, then the predictive value will be high. So another, just to show the difference in prevalence, high prevalence and low prevalence. Screening of with 90% sensitivity and 95% specificity. So you have all these numbers. So sensitivity is calculated here. So positive predictive value is 15.4. Negative negative is I cannot see here.
Negative which one, Prof?
Yeah, I cannot see that is hidden. What is the number below 15.4?
99.99.
99.99. Okay, you just repeat the same thing here also. So you can see that the specificity, when you increase the specificity, just now it was 90 sensitivity, 98. So now we just change a little bit, 90 to 98, to 98, 95 to 98. So you can see here, with this slight increase, you can actually almost double from 15.4 to 31.3. Yeah, and below is the same, isn't it? PB minus.
Yes, bro.
Okay,
99.9.
99.9. Okay, okay, okay. So just to show that if the higher is the prevalence, with the sensitivity and specificity maintain the same, then you can actually see the difference. So it is quite rare disease. The predictive positive value is actually very, very low. Whereas if it is a high prevalence, but it's 50% is almost impossible. But high, it means that the predictive value of your tools, of your screening tools, will become very, very good. Okay, we go to the next topic on reliability and repeatability of tests. Whether so there is one part of our sensitivity and specificity of the machine of a screening tool. Another component is in terms of reliability and repeatability. So this is actually a concern in the training of doctors. In the training of doctors, the for example, the BP reading, the BP reading always change when you tell yourself. It can change at when you if you measure at home. You go to the clinic. So normally when we are quite stressed, the BP will go up. So the first time that you go to see the doctor, the measurement will be high. So normally the doctor asks you to go out, relax a bit, and measure again. So that is quite common. So normally we have to repeat in the clinic, in the hospital, patient in the hospital. We have to repeat. So I just before we go further, just to mention about the COVID-19 test kit. So the reverse transcriptase polymerase chain reaction, RT-PCR, is a gold standard. It's a gold standard. So rated specificity and sensitivity above 90%. 90%, they are very high. Check on RNA and took 1-2 days for result. For SARS, almost 6 months to develop diagnostic kit, but only weeks for RT rapid test PCR. Only weeks for RT-PCR for COVID-19. Serology tests are used various antigen. Many. So there's for the serology test, they use a lot of antigen inside our blood and our fluid, whatever fluid. The rapid test kit actually can be done within 1 hour. Check on immune response of infected person. Okay. And have accuracy rate of 80%. Spain ended up returning a shipment of kits after finding that they had an accuracy of less than 30%. So this is the issue. So of course, for the currently we have lots of drive-through tests. You can see the price also there. Even home visit test. Test. So we have the PCR and in UKM, HUKM there is UMBI center here. I think the cheapest that I can find is about 200 ringgit, 200 to 250 at UMBI if you want to do test here at the HUKM hospital. Whereas other place is quite expensive. Okay. I think the concern is actually the Ministry of Health. Ministry of Health started with PCR. PCR. Anybody has got any idea why the government started with PCR? They don't follow the what we are being taught today. You are being taught today that you do the screening. Anybody want to offer a suggestion of why this is happening in Malaysia? That we use a PCR.
Prof, do you mind repeating your question?
Yeah.
Do you mind repeating your question?
Oh, okay. So as you know, when the COVID started last year in Malaysia, the government started with the gold standard test, that is PCR. Why do you think that the government of Malaysia started use not a screening tools like Selangor did now? They stress on the PCR, which is supposed to be a high, expensive, take time, and so on. Whereas rapid test is fast, 1 hour you can get the result, very cheap. Not very lah. It's almost 100 ringgit now, but it's getting cheaper. But the
Maybe
government,
because it's more sensitive.
yeah,
Maybe because it's more sensitive.
yes, more sensitive is true. Is very true because it is more sensitive. Anything else?
Prof, if the person take RTK, rapid test kit, and it's positive, he still need to take the PCR too, right?
Yes.
So maybe just to easiest, just do the PCR.
Okay. Yeah, what you will say is right. So if it is a positive, it can be false positive. Yeah, it can be false positive. So you have to refer to the center that has got the what call the PCR to test to confirm whether it is correct or not. Yeah, that's correct. But to those proponent of people like me in public health, we still believe that we should actually go all out with the rapid test. Rapid test because with rapid test we can do a lot because it is cheaper. You can do a lot. But I think it is more of like the government think that they can cope. They can cope with the numbers. They can cope with the numbers. So that's why throughout of last year, I think it is manageable. It's manageable until this year. Until this year that we have got these thousands of 7,000, 6,000 cases per day, where if ideally current situation, actually we should go for RTK. So what like the Selangor did is actually mass testing, so that once you got a confirmation, then you go. Because in the long run, I think that is much cheaper to do rapid test first, and you just those who got real positive cases, then you do confirmatory test. So it means that last year the government actually spent so much money on things that are at the end is quite useless lah, because you spend so much money with the confirmatory test on things that you can do simply. If negative, you can dismiss it. Yeah. So that is the situation. So I understand. Maybe I don't know. Maybe there is a question on what do you think of this? Okay. Okay, that's good. So the next phase, and I'm talking now is about two examiners. So this is actually in the training of pathologists. Example lah, pathologists or radiologists. In the training, we consider that the teacher is already the experts. So the trainer, if you are the new student, you want to be a pathologist, they will ask you to go through the slides of cancer cases, for example, and then you decide what stage and so on. So this is where we want to discuss here. So, so the reader, there are two readers here. So let's say number one is the teacher, the pathologist, the chief pathologist of the hospital, and when this is the trainee. So we have the abnormal, suspect, doubtful, normal. So the same thing with the reader. When he read, actually he may have a different opinion. So this is the situation. You have got A, B, C, D until P, and those who are what I call in agreement is actually abnormal. Both agree. Reader one and reader two agree. A. F is suspect. Both agree. K doubtful. Both agree. And P. So percent agreement is actually the total of these numbers plus A plus F plus P. A plus F plus K plus P is the total agreement. Divide by the total number of slides or X-ray, whatever, including those the other numbers, the other total numbers. So this only these four groups you are in agreement. So this is how the training has been conducted in our institution currently. Maybe in the future we use machine and we use computers, IT, AI, eye detection instead of human eye. So at that time, then we may not do this this training. Yeah. So, okay. Okay. So in order to measure this, we use kappa statistic K, kappa statistic, so index of agreement and reproducibility. So here it says even if two observers use different criteria to identify positive and negative, we expect them to agree by chance. So whatever it is, we are talking here about agreement by chance. This is how we want to calculate kappa. So so we have to calculate this kappa statistic. We have the percent agreement observed minus percentage agreement expected by chance. By chance. Okay. That would be the numerator. Okay. And then the maximum agreement. So the denominator for this calculation is what is the maximum agreement. For this is actually 100%. Both agree totally 100. So we consider 100% minus percent agreement by chance will be the denominator. So it looks something like this. So kappa equation K is percentage agreement observed minus percentage agreement by chance divided by 100% minus percentage agreement by chance. Okay. So now we go to this. The rest is actually all explanation. You can read later on. I just want to show you this situation where we have here about 75 slides of non-small cell carcinoma, grade 1, grade 2, and grade 3. When this pathologist A and do the rating to the grading. So for pathologist A, he actually identified 45 of grade 2 and 30 of grade 3. Yeah, below. Total of grade A is 45. Total by A and grade 3 30. Yeah. Whereas pathologist B, his grading of grade 2 is only 44, slightly only one miss, only one missing. So this is very good actually. Grade 3 31. So just a matter of one only. So here total of B 44, 31. 44 grade 2 and 31 grade 3. Whereas grade 2, 45, 30. Just a matter of what I call one difference only. Okay, so here we look at the agreement. The agreement here would be this is agreeable. Grade 2 by the 41 here is actually 41. 41 out of 45. 41 is agreed by both. And then grade 3 actually 27 agreed by both. By both agreed. So the total, so we have to add this and 41 plus 27 divide by 75. Divide by 75. So we got 41 plus 27 divided by 75, we got 90.7. 90.7 is positive agreement. Positive agreement. Okay, so
Prof, this is the observed positive, right?
observe. Observe based on this one. So pathologist A look at the slide. They look at the slide and both of them, A and B, agreed that 41 is same. So there is a difference of only 3 and 4 only, because the one that is grade 2, 4, there's 4 graded grade 2 by pathologist A is considered as grade 3 by pathologist B. So these are the non-agreement, and 2 for pathology B. These 3 grade 2, but it is actually graded as grade 3 by pathologist A. Okay. Okay, so this is a percentage agreement by both of them, 41 and 27. Okay. So now we go to this. So we go here, percentage by pathologist A and pathologist expected by chance alone. So now we want to calculate. How to calculate percentage by the pathologist A and B expected by chance alone. So what you should do is actually okay, you take okay, pathologist A is the percentage of his grading. Grade 2 is 60%, grade 3 is 40%. Yeah. So what you should do is, in order to calculate expected by chance, you take this 60%, you multiply by 44%, 44 slides of grade 2 by B. Okay, 60% times 44 you will get actually 26.4. Boleh tak? Can you
Prof,
do that?
why times 44, not 41?
Times 44. Because this is, because now this is the pattern. Is the pattern of this is the what called the mind of the pathologist A. Because we cannot change it, because the way he is rationalizing his finding is in this situation. Whatever slide that we give, his finding is like this. So we take use of this in order to measure by chance. By chance, we take the 60%, his rating of 60 and 40. So we have to measure when we talk about by chance of the numbers of slides of pathologist B. Pathologist B said grade 2 is 44 slide. 44 slide. So how to do this by chance? That is the way to do it. 60 times 60% times 44. I'm doing also the same thing here. 44.
Also, Prof, we take the percentage of A multiplied by the total of B for grade 2, is it?
60. 60
Percentage
times.
of A times the total of B, which is 44.
Yeah. Okay. So you get 26.4. Yeah. 60% times 44. You get 26.4. Yeah.
Okay.
Okay. For uh, the other similarity, the other agreement is that grade 3, both grade 3. Yeah. So how to calculate that one is actually 40%. 40% of the grading grade 3 by A, 40% times 31. You will get 12.4. Okay. The other two place, the non-agreement, actually if you do the same thing, there is 60, uh, uh, six, 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 no, 60, 60% times 31, times 31 slides, you will get 18.6. And for the grade 3, you 30%, 40% times 44, you will get 17.6. So this is how to calculate what is expected by chance, the possibility of chance alone. And in fact, you can actually reverse the situation. The situation. You take 58.7%, 58.7% times 45. 58.7% times 45, you will get also 26.4. And you use the same 58.7 times 30 slide for grade 3. Is actually the same thing, 17.6. So either way, you use 60, 40, 60 and 40, or use 58.7, and you times the numbers of the slide of the other person. You will get the same thing. You will get the same thing. So this all by chance. Okay. Clear? It's not easy. That's why I said I hope you have read earlier. But this is the explanation. Don't worry. This is the explanation you can go through later. What I want to show is here the agreement by chance. The agreement by chance, because our calculation in the formula here, percentage agreement by chance. We have to use both minus observed agreement observed, percentage of agreement observed minus agreement by chance. 100% minus agreement by chance. So we have to have that number. We have to have that agreement. Okay. So the agreement by chance is 12.4 divided by 75, 26.4 plus, itulah, ni. 26.4 plus 12.4 divided by 75, total is 51.7. So this is how we finally calculate lah, that 90.7 minus 51.7%, divide by 100 minus 51.7, still 51.7 because of the agreement by chance. So it comes to 0.81. Okay. So when you got, so this the quotate the kappa punya quotation here, we get 0.81. So you look at here. Kappa more than 0.75%, 0.75, excellent agreement beyond chance. K below 0.4, poor agreement. K between 0.4 is intermediate to good agreement. So in our case, we have
This
got
excellent agreement.
excellent. Yeah. So you look at the difference is only one. Only
Only
3 and 4.
one slide.
So, yeah. So you mean that these 2% actually excellent. They are excellent. So that is how in calculating the agreement between the 2% in the training. So they will use this kappa equation to measure. Yeah. Okay, so we talk about validity and reliability. Of course, we want if the curve is narrow, it is reliable. But if it is outside the true value, then it is not so valid lah. Whereas if it is broad, even though it is on the, it is not so low reliability. So what we need is actually at the center, the true value with a narrow. So another presentation is like this lah. Reliable, not valid. You get at one corner only, but not at the center. Or if it is all over, so it's valid but not reliable. So like the third one is both not reliable or not valid at all. So what we need is actually at the center like this, both reliable and valid. So this is how to make sure to in the training that they want reliable and valid. So that's why in the training of pathologists, for example, or radiologists, these are tools that are used. Maybe other tools that what we know is only this one. And it is through this actually you develop the skill of these pathologists. And of course, in the system that we have currently, the pathologists, the pakar, all they when they got their master's degree, they are not yet pakar. They will posted to the hospitals, and then they are under the supervision of the head of department of the particular, for example, pathology department. They are under that as a pre-gazettement. They are not yet gazetted. Pre-gazettement period of 6 months. So only when they have gone through the under the supervision, so the head of department would be monitoring their performance every now and then, make a cross check and so on, spot check and so on. Only then they will be considered as reliable. So then they can only be endorsed as a pakar. So that's how in our healthcare, because we talk about the safety, we talk about the quality of care to the population. We do not want mistake to happen. So this is how the training goes. So that's why you have to have a passion. You have to first you have to have an interest in the postgraduate. What are the area that you want to be? What are the things that you want to continue to pursue your any? And later on, because when you have got your passion, you are already keen, committed to do this particular pathology, for example. Of course, you will find that you are very happy with it, you like it, and so on. So this is how we develop skills. Okay. Okay, so there are some reference. Actually, you can go to Leon Gollis, chapter 5, page 71 onward. Is actually much of the information that I gather. Actually, you can get from there. You can go to other books also. Okay. So I think that's all. I already exceeded half an hour of your time. So any question?
Prof.
Yes.
For the screening, the person who went the screening and it is positive, he needs to undergo the confirmatory test, right?
Okay. It depends on the screen. What are the type of screening tests? If, for example, blood pressure, you take the BP, you screen the blood BP. So most likely you can just advise him to go to hospital or to the clinic to verify lah. Or you go to another person, another doctor, use a proper, because we use a sphygmometer. Sphygmometer that has got a mercury. That one is more accurate. So not necessary, but you can alert the person. If it is mild, slightly high, you can actually tell him that you can start to take care, do exercise, take your diet and so on. So not necessarily must be referred, no. Because sometimes our student, when you do your third year, we hope that you can go to do studies at home. You take the BP of somebody or take the blood sample kan. Suddenly it's slightly high. So you can advise them to go, but not necessary. But if it is something that is very sensitive, like HIV, so positive, so it is a shock not only to you but to the person. So these things like this, if it is a screening, you can refer for confirmation.
Let's say we take example COVID, right, Prof? So it's definitely need to confirm the test, right?
Okay, now of course lah, now you go to hospital is PCR, so it's already 100% already. But if you go, for example, you go to clinic, GP, they test you positive. Actually, immediately they will ask you to go to the hospital to confirm it. So PCR will take another 1 day. Now it's 1 day. I did for my mate the other day is at Umbi. I went to Umbi actually. It's 1 day. The next day you get the result. So
But
yeah.
What about if the screening is negative, false negative? So how can that person know at last he's actually positive?
It's a very good question.
I think eventually he will eventually have the signs and symptoms, so that's when you know he's positive.
So it will actually also increase the person under suspicion too, right?
Yeah.
This is the issue, the big issue, because if the person is false negative, kan? Because we know COVID is not like SARS. SARS 2003, SARS, severe acute respiratory syndrome, SARS. Also by corona, this is coronavirus kan? This is SARS-2. SARS-2. Last time is SARS-1. This coronavirus, the majority is asymptomatic. This is the main problem. The previous one, SARS, you got it. There is no asymptomatic. You are true admitted. So that's why all over the world, it's only 8,000. 8,000 cases all over the world. And 800 died. But this one, so that one is 800 is 10%. Mortality is 10%. This one is not 10%. Depending on countries lah. Some ours is very low because the majority is symptomatic. But the problem is the carrier, those who brought when it goes affect the other person, tak semestinya the other person is like him. That is the problem. The other person can can get it from this normal asymptomatic person, and the other person landed in ICU. So this is the situation with COVID-19. That's why we have to make sure get all your ada yang dapat ni dah dapat jab.
Some of us are still waiting. Ada yang dah dapat dah.
Ada yang dapat, good lah. Try to get lah. This is the only way. The only way we want to reduce. We want to increase the herd immunity, and we want to reduce the situation. So yes.
Prof, for the
Go John.
for the attendance, you need to give a question, Prof.
Pardon?
For the attendance,
Uh-huh.
you need to ask a question.
I should give question, is it?
Yeah, one question. Then we have to type the answer in the attendance form.
Oh, okay. One question, offhand. What give one criteria for WHO guideline for screening.
Prof,
Hmm?
for slide number 80,
Number 80,
80.
okay.
Why do we need to multiply the percentage by the number of slides that the pathologist use?
Okay. Because we want to calculate the what I call the agreement by chance. By chance. That's why I when I show just now. This one. This is calculation. How to calculate by chance? Because at the end of it, the formula needs to calculate by chance. So it means that because the grading are different, both of them has got their own way of grading. Pathologist B also different. So we want to calculate what is in between them, the possibility of identifying the same thing by chance. That's why when you calculate 60% times 44 slides, you will get this number. If you multiply 58.7% by 45, you get same number. This is how to calculate by chance. It means that this calculation is the same. You get what I mean? That is by chance, either way, by A or B. So you want to calculate A, considering to calculate the possibility by chance of his finding with pathologist B, you multiply 60% times 44 slide of grade B pathologist. But you want to do the other way around, you take 58.7% times 45 of grade 2 of pathologist A, you will get still the same, 26.4 slides. 26.4 slides, and the agreement by chance. Chance, if you maybe if you read through, you will understand what is meant by chance. All these figures are actually here on this page is actually by chance. 17.6 by chance. By chance.
Alright.
I hope you read my the writing. I think it is quite this one kan. So 41, 27 is agreed. Only 3 not agreeable, and 4 not agreeable by both of them. So now we are calculating. What is the agreement by chance. So the way to calculate is actually 58.7% times 45. You want to calculate a grade 3, 58.7 times 30. So you get this at this 3. But if you reverse the percentage times the other slide of the other person, you will get the same thing. Yeah.
All right, thank you, Prof.
Okay, thank you very much.
Prof, will
Yes,
this kind of calculation come up on the exam?
don't worry. At the moment, not yet. So read the others first.
All right, Prof. Thank you, Prof.
Okay, thank you. So okay, thank you very much. I hope you have been since 11:30. Almost 3. So okay, thank you very much, and Assalamualaikum, and good day, and stay safe, inshallah.